Good evening, or good morning, or good afternoon, everybody at Virtual Global Spine. Welcome to another session hosted by me, one of the faculty members of the Virtual Global Spine group. Today, I'm going to be talking about a relatively new topic for me, not a relatively new topic in spine in general, but a kind of my experiences with endoscopic spine surgery and how I got interested in it in the first place and how it's becoming a rapidly growing part of my practice. And it's very interesting and very different for me to say that because, and I'll get into the reasons why that is, but I'll say I was very skeptical about endoscopic spine and some of the applications of it. And after I really got to look at the technique and learn the technique and actually practice it myself, I have to say that I'm quite a believer now, as interesting it is to say, because if you talked to me about a month ago, I would have said a very, very different story. So I just want to give you an idea of what my current practice is, or rather was prior to learning endoscopic spine surgery. So the vast majority, so I kind of did an audit of my cases in the past 2 years. And basically the majority of my cases are deformity and bread and butter degenerative spine surgery. So of the deformity, I do mostly revision surgery. So the vast majority of those patients have had prior spinal surgery before. These are mostly flat back deformities, pseudoarthroses, patients with quote unquote failed spine surgery, iatrogenic deformity, kyphosis, you name it. So that's the majority of those deformity patients. And once in a while, I'll get a de novo patient with adult spinal deformity who's never been operated on before, such as this patient here. And I would say probably about 90% of those patients are osteoporotic spinal deformities. Of the degen, I do the straightforward ACDFs, T-lifts, X-lifts, A-lifts, and microdiscs. And of those cases, basically, I'll even say it's probably 99% open with 1% MIS. And the reason for that is multifactorial. It goes a lot into my training. I did a lot of open surgery in both my residency and in my fellowship, and I kind of took those techniques and I carried it over to my current practice. I'm not a big believer in MIS. I would say that the vast majority, I cannot tell you how many patients who have had horrible spinal surgery histories where it all started with an MIS TLIF. Many cases of those patients, it all started with MIS TLIF, or an MIS tubular decompression. There's so many things. The MIS definitely has its advantages, and I don't really want to get into open versus MIS. This talk can go on and on and on forever. But I'll just say my general gestalt before going and learning endoscopic was that I'm not really an MIS guy. I don't really like it very much. I do pretty much everything open. I do open T-lifts, I do open microdiscs with a McCullough retractor, so on and so forth. And then basically the last 10% are just the random things that'll come in on call, like trauma, infection, tumor. And in some ways, those are also deformity in a way. So you can count that into that. So, I've been in endoscopic, or rather I've been in virtual spine now since the inception in April of 2020. And I can't tell you how many countless cases and countless presentations of endoscopic spine surgery we have seen, right? And I would say, the vast majority of them are very, very pro. I can't really think of too many where people were saying endoscopic was not a good approach, right? The vast majority of them are practitioners or surgeons who are very comfortable, very facile with endoscopic spine surgery, who are coming here and boasting about their techniques and really trying to pump up the technique. And I didn't really see the point. I mean, what was the benefit of it? Why is it better than dropping in a tube, right? Why is it that the patients, if you're doing an endoscopic discectomy versus an open discectomy or a tubular discectomy, from my experience and my practice, all those patients are going home the same day. And I could even argue that it could be possibly even faster in some ways to do it open or do a tubular, and you don't even need that much X-ray in those cases versus how much X-ray you need in endoscopic. So when I actually started doing endoscopic for the first time, the majority of it was during my fellowship, and it was I would say not. It was a challenging experience. It was a lot of these cases took a lot of time. There was a lot of fluoro. There was a lot of futz factor with them. Holding the instruments, I didn't like that. I didn't like how much X-ray there was in the case. They always took longer than just doing a traditional open. So I didn't really like it. I didn't see the benefit of it. I would watch Virtual Global Spine. I read about it on LinkedIn and on Twitter, and people posting all these really nice endoscopic cases, and in particular endoscopic fusions. And I just didn't really buy it. I didn't really see it. It wasn't my thing. And I just continued doing things open. So things have changed. Things have very changed. I'll kind of circle back around to this, but I just want to kind of instill that I was not a big believer in endoscopic. I was not a big believer in MIS. I do basically, the vast majority of my stuff is done open, large incisions, big deformity cases, T-lifts, or rather PSOs, PCOs. That's like the majority of my practice. So anyway, so how did I get interested in the first place? So endoscopic, right? So what is really endoscopic? When I think of it, I mean, you can think a tubular discectomy, you can almost say that's endoscopic in a way, right? You're dropping in a tube, and with an endoscope, you're almost dropping in a tube as well too, right? It depends on how you're selling it to the patient or speaking to the patient about this, right? But what's really truly what we call fully endoscopic, right? You're making a single incision, very, very, very tiny incision. And you're working with an endoscope that's under constant irrigation, right? You're working in a liquid medium. You're working in a setting where the field has fluid, has water. And that's what really distinguishes that. And also you're looking at a monitor as well too, right? That's what really distinguishes that from tubular approaches, right? And you can just see it just in this illustration. I really like this. This is basically exactly what it is. You're one-handed, you're holding the scope, and you're working through this portal, through this channel, through a dilator, and doing your procedure. So really, what the beauty of the endoscopic approach is just that it's so reliant on the imaging and the equipment. And as you get, and it's the same steps and same procedure every time. And as you get more facile with this equipment and you get more comfortable holding it and you get more comfortable doing these procedures, the benefit of the endoscopic approach really becomes very rapidly apparent. So once there are many different styles and techniques to get access to the disc space, for example. But generally using a spinal needle, right? Once you get under fluoro, once you get access, once you kind of get transforaminal, you get down into Camden's triangle, you start introducing your equipment over the spinal needle, right? So you do a dilator, you get a cannula or a sheath, and then you actually enter your endoscope inside this. And then at some point as well, especially if you're doing an endoscopic foraminotomy, and you're going transforaminal, you would introduce several reamers that are increasing in size in order to perform your foraminotomy. So once you get down to once you're kind of have your endoscope in and you're comfortable and you got everything going, then it really comes down to the equipment that you're using. So really, this is kind of the standard setup for, let's say, an endoscopic translaminar discectomy or transforaminal approach, right? You need bipolar electrocautery, which is probably your number one most important thing and your best friend. And you should be very general. That's just something I learned early. This is your best friend. You really want to buzz a lot of stuff. You want to make sure your field is clear. You want to make sure that you know where all the anatomy is, because it's a little bit weird at first. You're kind of not sure. You're holding the scope. You're looking at the screen. It's very disorienting. But as soon as there gets some bleeding, and you can't really cauterize it, the pain factor of this procedure is just through the roof. It can your field saturates red. It's hard to get control over. You're constantly irrigating. You're looking around for it. It's tough. So I would say this is your best friend. Your bipolar is your best friend. Get comfortable with it. Get comfortable holding it. Get comfortable using it. It's curved. It's like almost like I call it like a snake, basically. You kind of get it into crevices and areas of your field, and make sure you're using it well. This is super, super duper important. The drill also important as well too. I would say not as important as your bipolar, because you also have you're going to do the majority, if you go through transforaminally, the majority of your drilling, quote unquote, is done with the reamers. So, and that kind of is the procedure, right? Which is really nice with this. And then again, you have constant irrigation in the field. Now, and then you have your display and tower. Now, depending on the company you're using, we use Eloquence at Northwell. What's nice about that is that they can plug and play in majority of different towers. So the one we have a striker tower, and we use Eloquence just plugs right into that. So you don't have to buy a separate tower, which is nice. At first, right? I was very worried with my first endoscopic case because I felt as though my OR team didn't know what to do. How they don't know about the equipment. Always the first case is kind of scary for both the OR staff and the surgeon because you're learning something new. Everyone's kind of learning something new, but actually that wasn't the case at all. They were actually very comfortable with this. In fact, they were more comfortable with this equipment than I was. Why? Because of general surgery and ortho and ENT, they use this stuff all the time. So actually, I would argue it was actually even easier than a normal spine case. They never even asked me about, every time I do a spine case, and let's say in certain places where they're not comfortable working with me, I'm getting peppered with a million questions. What cast do you use? What's your glove size? What table do you want? Do you want a Wilson frame? Do you want this frame? Right? Oh, are we going to use this kind of retractor? With this, no problem. Everything ready to go. They didn't barely ask me any questions. They knew how to set up everything. They knew how to do the white balance on the scope. It was very good. So it was actually a very nice experience, and I was very pleasantly surprised by that because the staff was so comfortable. They knew where to put the tower. They knew where to put the scope. So it was very comfortable, and I like that a lot. And also my scrub tech was comfortable with the equipment. He knew exactly what I wanted. It was good. And it happened to be that my first case was one in a kind of a small ambulatory spine center that was not comfortable, where I had not really worked with very often, but it was a very pleasant experience because they knew exactly how to work with me. So what's nice about the endoscopic approach, right, is the versatility of the different approaches, right? So you can do, this is basically, this is for anything, right? So you can go central, lateral recess, foraminal, and far lateral, right? So if you're going to go translaminar to do, let's say, a translaminar discectomy, right? You're not really going central. You're really kind of going right paracentral, or you're going not right or you're going directly paracentral here. And your angles of approaches are going to be variable depending on where you're going to land and what you are trying to achieve here. So that with the interlaminar approach, which is really kind of the favorite approach for central or paracentral disc herniation, you could theoretically do it transforaminally if you have angled instruments, but I wouldn't recommend doing that for your first case. When you're going with the interlaminar approach, right, you're kind of docking right at the area of the disc space. So what's nice is, I'm just showing you the kind of different ways of doing it. So this is these are different terminologies for the different approaches. This is the interlaminar endoscopic lumbar discectomy. This is more of a, if you're going over the top, as was described by Dr. Hartle at Cornell. This was an endoscopic unilateral laminotomy for bilateral decompression, where you approach from one side, but you achieve decompression on both sides, or over the top laminotomy or laminectomy. And then you have also the interlaminar contralateral lumbar foraminotomy. These are all different terminologies. It can get a little bit confusing, but it's very versatile, just like tubular discectomies are, where you have a microscope and you're kind of down, you can angle the tube how you want. The endoscopic approach offers the same versatility, which is nice. So it's really, I'm illustrating the interlaminar discectomy, endoscopic interlaminar discectomy here. So what's nice about this is that you visualize everything here, okay? So when you first, this is just illustrating the point. So you first dock, you see the thecal sac. You're going through the ligamentum flavum, right? You're getting down to the disc space, and theoretically you're kind of landing right at this junction, right, of the, you have your descending nerve root medially, right? As he has an angled instrument, your descending nerve root and thecal sac are here medially. And this is your exiting nerve root laterally, right? You're landing right on the disc. You rotate it out so everything gets out of the way, and then you work right here, right? So what's nice is that you see everything as you get down. You see everything that's moving around, which is really nice. Sometimes this disc can really displace everything out of the way, and then you don't even have to do that really. But what's nice about this is that it's as you get comfortable with this approach and the endoscopic approaches in general, these maneuvers become less scary and they become more natural, and it becomes almost a very easy process in a way. So with the Cambin's, it's all about Cambin's triangle, okay? Like this is literally it. This procedure was devised because of the anatomy of Cambin's triangle, right? So theoretically, you have this space, right? This little interval here where you can introduce a very small instrument, but you can do a lot of work through this space. You can do basically anything you want. Because as soon as you get into this space and you're docked in there, you're securely in there, as far as I'm concerned, the case is kind of is over, right? Because then you're just getting your instruments in, you're pulling disc out, you're doing whatever you need to do, and that all that stuff goes pretty quickly. So the key is getting right into this interval right here. This is the key. Okay. So, but here's the thing. When they discuss Campbell's triangle, right? It's always like in textbooks, it shows you, some variability depending on the patient's anatomy, so on and so forth, right? But what in the real world, right? Is it really like that? Do we really have that? Do we really have that ability to get into Campbell's triangle? And so in reality, right, it's actually quite difficult, right? So in this was an anatomic dissection in 2017. They found out that there was basically a very narrowed or no space, or basically very minimal space in this category study, about 80% of patients, right? So it's either no triangle or a very small triangle. So it can be very, very challenging. So what's nice about, and this kind of harkens back to the endoscopic approach for this, because you have such a small space, and you can use your instruments to to get access to the triangle, wherein generally it's pretty small. Now, looking at the anatomy of the intervertebral foramen, right? So if you're doing, let's say, a transforaminal approach, right? It's pretty complicated. It's not just nerve root and whatever degenerative osteophytes have developed over time that you're trying to get rid of, right? There's a lot of ligaments, there's a lot of veins, arteries, things like that run through this. So what we try to do is in many ways, right? And these ligaments suspend the nerve, right? And now obviously as patients develop arthritic and spondylotic changes of the spine, these things basically get obliterated and they're not really existent, or neither are they. They're neither existent nor clinically significant. But our goal is to kind of preserve the anatomy as much as possible. So my favorite approach with endoscopic, right? If we look at, these are all variants of similar themes, but my personal favorite approach, where I think this procedure really, really shines, is the endoscopic endoscopic foraminotomy, or transforaminal approach. This is really where I think this procedure is just truly outstanding. Okay. The reason I say that is, in my practice, right, I do a lot of lam forams. I do a lot of foraminotomies in patients, meaning I can't tell you how many patients I see with unilateral, bilateral radic, degenerative disc disease, foraminal stenosis, right? Many of these patients can benefit from just a simple bilateral laminar foraminotomy or interlaminar foraminotomy, where you basically drill away some of the inferior and superior lamina, a lower portion of the medial facet, and you try to maintain as much as the midline lamina and spinous process as possible, right? You're basically opening up that foramen. But the problem is with this, right, is that you're basically going inside out, right? With a tubular and open approach, you're going inside out to do your foraminotomy, and you're drilling away bone. The beauty of the endoscopic foraminotomy is that you're achieving the same result, but you're going from outside in. Okay, so you actually you're preserving all the midline posterior ligamentous structures, the soft tissues. You're preserving all this, which is wonderful, right? And you're achieving the same result. And that's where I think the beauty of this approach is really this transforaminal, or the endoscopic foraminotomy. I love this approach. It's completely a different procedure and completely a different approach from the conventional open and tubular approaches. Okay. And I would even go so far as saying this is a procedure in and of itself. Like, this is endoscopic foraminotomy. That's the way I say it. I don't even think of it as comparable to a tubular foraminotomy or a open foraminotomy. This is something completely different. So there have been, there is evidence, there is literature. It's not like this procedure is I may be acting as if this procedure's been around relatively recently. It's just coming to my world relatively recently, or I guess my stratosphere, because I've never really, mostly done open surgery, deformity surgery, so I never really thought about endoscopic. I always thought of endoscopy as kind of an MIS thing for an MIS surgeon, but it has many, many uses, I would say. So there are tons of papers out there comparing endoscopic versus open, right? The problem is, as with any of these studies, right? The majority of these are retrospective, right? They are small cohorts, and there can be conflicts of interest. And whenever you have an intervention where the majority of the evidence is retrospective in nature with conflict of interest, you always must think about the possibility of a therapeutic illusion, right? Where people are we have confirmation biases and all kinds of things that can alter the realism of the approach, right? So you always have to think of things skeptically when you see a couple of thought leaders in a field really, really talking about how wonderful endoscopic is, right? And you can say the same thing about anything with spine, right? The MIS guys, all great MIS papers. Deformity, my world, deformity is great. Open surgery is great. MIS is terrible, right? So you always have to think about conflicts of interest, therapeutic illusion, all these things, right? So I tried to pick, I cherry picked these studies. I will say I cherry picked these studies because I wanted to make sure that I wanted to kind of give you a neutral approach, right? So this study was a prospective randomized study where, and obviously it's not blinded, of course, right? But they saw that there was really no difference versus open versus discectomy versus conventional microsurgical techniques. There's interlaminar transforaminal approaches versus conventional microsurgical techniques. There's really no difference between them. What they saw, however, was that the patients had less back pain. They did better with physical therapy as an outpatient. There were less complications and theoretically less trauma to nerve roots and fecal sac, less CSF leak. All these things should make sense, right? I mean, this is all of it's nice. They looked at recurrent discs as well too. Okay, not just or rather the recurrence of. I didn't say that right. Was there an increased risk of disc herniation with endoscopic versus open? And really, there was no difference between them in this prospective study. So I kind of read these studies, and I was kind of like, all right, here's another one looking at treatment of lateral recess stenosis with endoscopic versus microsurgical technique, right? Another study, and you can see actually these are all the same. These are all the same authors, right? So I read this, and I really wasn't too impressed. Okay, as I thought, they're the same. There's no difference. Patients do the same. What's the big deal? Okay. Now, here's the thing. You can see a certain theme. Okay. You can see a certain theme. Here's another one, for example, right? The theme is that there's no difference in complications or theoretically outcome, but these patients do better. Okay. They do better. They have less pain. They're up and walking much faster. They're out of the hospital much faster. They're happier with their surgery. Not that this really matters to me, or have I really cared about, or have I really seen it matter too much? But when I bring it up, they are very happy with the size of the incision as well too. You're talking about literally a stab incision with a number 15 blade versus a slightly larger incision with let's say a conventional open approach. Again, that's the least of the patient's concerns from my personal experience. They really don't care about the size of their incision. They're really just concerned about relief of pain. But you can see that there was a general theme of patients doing better, even though the outcomes weren't very different, right? So there's a signal there, and that's what I liked about it. So anyway, this is I've seen this chart. I think every endoscopic talk I've seen this chart, and I really hate this chart. But I want to ask you, and the reason I say that is why. Right? You can say this about anything in a way, right? So like as you go from least complex to most complex, right? And you can say this about any intervention, any procedure, right? So really what they're saying is the benefit zone of endoscopic is really with is really with kind of the more conventional decompressions, right? Where you're not doing a larger incision, where you're not using the drill as much, where you're not disturbing the posterior ligamentous complex or taking down the spinous process, taking down the supraspinous, interspinous ligaments, taking down the ligamentum flavum midline. You're not doing that stuff. You're coming from outside in, right? You're kind of bypassing all that stuff and getting right to the area where your problem is, right? It's a very targeted approach, right? So when I kind of learned that and I kind of had that idea in my head, I realized where this was different from a conventional tubular approach, right? The tube is not really endoscopic. The tube is more of an open approach, right? It's just a smaller open approach. So those are more comparable. I would argue that endoscopic is not really the same as those. It's a totally different procedure in and of itself, right? And if you kind of look at some of these trials, we kind of bring the summary of these trials, and what they did in this paper, they compared to the sport trial. One of the papers that we love to cite about lumbar fusions and so on and so forth. You can see that in general, right? In general, the complication rate was very low, right? And in particular, it was with dural tears, infections, and the overall complication rate was very, very low. A lot of these reoperation reherniation rates in this paper, these were found early on when they were still learning the techniques and they were still getting comfortable with the instrumentation. But as these have improved over time and the equipment has gotten better, these have really come down, right? So this is actually quite nice. So really the advantages of the endoscopic fusion surgery, if I was going to really kind of summarize this in my head, because I kind of thought about this a bit, the benefit really is now I disagree. This one I had to kind of think about. I mean, yes, it can theoretically, if you get comfortable and you have a good team and you get access quickly with the spinal needle, it can be shorter OR time. It can, right? But you have to get comfortable with that. It's going to take some time for you to get to this point. What's nice is that also this opens up the door theoretically for the possibility of doing procedures under MAC, right? So there is a growing number of spine surgeons who are trying to do awake decompression, endoscopic decompressions, awake spinal fusions. And what's nice about this is that you really get the ability, this opens up this avenue, okay? Whether or not that's important to you or whether or not that's significant for your practice is a separate story. But if it's something that you wanted to do, this unlocks that door for you. Because I don't really see how you can do this with open or tubular approach. It would be much more difficult, much more difficult. Certainly, there's less epidural scarring, because especially with the transforaminal approach and the interlaminar approach, you're really not messing around too much with that. You kind of move everything out of the way, which is nice. And you have a tiny, tiny, tiny little incision. So if ultimately the patient needs to be revised or you wanted to do something else, you have such a very atraumatic approach to this patient, right? It can be done ambulatory as with anything, but this is truly like, there's really no reason for this patient to stay. Even if you do multi-level, usually if I'm doing more than 2 levels foraminotomy, I usually keep the patient a day. Here, I'm sending these patients home and I'm routinely doing 2 and 3 level foraminotomies, and there's very minimal EBL. It's basically 0, right? So it's nice, and these patients don't have too much pain. They're really doing quite well after surgery. I mean, I give them like 3 days of Percocet, and they're doing just fine. Now, I'll actually, before I get to this, let's talk about, okay, so I saw Dr. Burchuk said, do you see endoscopic decompression replacing some of the cases you would have previously fused? 100,000%. So I see a lot of patients. I'm going to go back actually. All right. Yep, Dr. Gardaki, I completely agree. Why give Percocet at all? Completely not needed. Unfortunately, I often deal with patients who have been seen or have gone through the ringer of pain management. They're already on opioids or they are expecting opioids, and I really try to get them off of it as soon as possible. I found that select patients very select patients. I try to avoid it altogether. I just send them home on NSAIDs and they're just fine. Or I just tell them like, hey, I'm just going to give you some Motrin, you'll be just fine. I think if you put that in their head that they're not going to be sent home with Percocet or they're not going to be sent home with any sort of opioid medication, you're kind of fine. And I think that's really where you want to be. Let me go back. All right. So this patient, for example, this case of mine, right? How many times have I seen a patient with this kind of a curve coming in with unilateral radic, right? And has like very significant foraminal stenosis, predominantly on, let's say, the right-hand side at on the concavity at like 3, 4, 4, 5, right? How many times do I see this patient? And it's like, patients like, let's say 75 years old, osteoporosis, has right-sided radiculopathy with this kind of a curve and foraminal stenosis at 3, 4, 4, 5. I mean, so many of these patients, right? So what would I do for these patients? I generally would not do this. What you see on the right, this is a very different story, right? But what I tried to do with these patients, I would start with a foraminotomy, right? So I used to do open, I go down, I do a foramen at 3, 4, 4, 5 on the patient's right-hand side. The patient usually had a lot of pain post-op. They usually go home the same day, but they had pain and it took a while for them to get better. They ultimately did well, but it took a while for them to get better. But the incisions were big. There was a lot of trauma to the tissue, to facet. I didn't feel good about it, but the patients did fine. And it was my standard care. Now, if the patients came back, let's say 3, 4, 5 months later with recurrence and more back pain, then I would talk with them. Usually my next step would be like an XLIF, like for this patient who has a significant coronal listhesis, I would do like an XLIF, or I would do, something a little bit more, but it just depended on the patient, right? But here, this is the perfect patient, I think, for an endoscopic foraminotomy, right? You're coming from outside in. Yes, the anatomy is a little bit more challenging, but you can rotate the bed. You have tricks, things that you can, and usually once you prone them, a lot of this curve kind of straightens out, which is nice. But you have tricks. There are things that you can do, and you're so atraumatic. You're not disturbing any of the posterior elements, because you always worry about progression of this curve, right? I mean, their bone quality is pretty terrible. That's why this happened in the first place. So what are they relying on? They're relying on the disc and the ligaments, right, and the joints. So by disturbing that, you're basically disturbing whatever reserve they have, and that's what kind of may tip them over the edge, right? So what's beautiful about the endoscopic approach in a way is that you're leaving all that alone. So these are the patients, I basically, this is like my go-to for endoscopic foraminotomies. Once I got it, it took me a bit to get comfortable with this, but once I did that, this is my standard of care for these patients who present with like let's say a spinal deformity like this, which is many, innumerable patients I get who are like this. Endoscopic foraminotomy with unilateral dick, right? Endoscopic foraminotomy, no question. This is I think, in my opinion, one of the best indications for that. So yes, Dr. Burchick. So these were patients where I would consider fusing, doing XLIF on them, possibly doing let's say an open foraminotomy. These patients are all getting endoscopic foraminotomies now, because what's nice about it is that they do quite well. They really do quite well. And in many cases, that's all they need, right? And then, hey, guess what? Maybe 1 year, 2 years from now, if they ultimately need deformity correction, fine. But you gave them some good quality of life for that period of time, and you did something that was essentially atraumatic. You don't have much scar tissue. They don't have an incision to deal with, and if they come back, fine. Then you give them a bigger surgery, but that's fine. At least you gave them that nice quality of life for a couple of years. So, okay. So going back, so endoscopic fusion. Okay, a little bit more controversial. I haven't really done many of these. I did one with a few of my partners, but I'm not one kind of on my own yet. And the reason I say that is I'm still kind of old school when it comes to, I do just very traditional T-lifts. I expose the transverse processes. I do posterior column osteotomies. I do bilateral annulotomies. I really get into the disc space with the paddle distractors bilaterally. I try to decorticate as much bone as possible. I lay down a bone posterolaterally, put it inside the disc space, lay it down. And that primarily comes from my personal experience doing an MIS TLIF. So when I first graduated from fellowship and I was like kind of on my own, I was kind of an MIS guy, believe it or not. I was an MIS and robotic guy. And I did all MIS TLIFs. And, when I was in residency, right, I did a ton of MIS TLIFs. But the problem was I never saw these patients again, right? I never followed them in the office. I would just see them for that one surgery, and then whatever the time was post-op, and usually those MIS TLIFs do pretty well post-op. They go home either the next day or within 2 days, right? They're doing pretty well. I never saw them afterwards, right? So I never knew what was the fusion rates, how are these patients doing? Are there any complications post-op, right? So in my mind, I was like, oh, MIS TLIF is great. The patients go home this post-op day one, they're doing fantastic, this and that. So I was doing all MIS TLIFs. And then I started seeing my own complications. I was seeing subsidences, I was seeing pseudos, I was seeing patients not doing great. And I was wondering what was going on, because I felt like my technique wasn't drastically different from what I did in residency and what I saw my attendings do. So, and I felt if anything, I was maybe possibly more meticulous than certain other people I work with. So I said, okay, and I talked to a couple of people, and what I found was a lot of things that were now being incorporated in MIS TLIFs were things that I didn't really like, and I didn't see the benefit in it. So some of them would be like doing bilateral posterior column osteotomies, taking iliac crest in an MIS method with a small disposable reamer. Like you make a little incision, you drop this little reamer down, and you grab some iliac crest and you pack that into the disc space, right? To me, that felt like you're basically doing everything. It's basically an open case, but you're just using a smaller incision, right? And I didn't really like that, and I felt like you're kind of missing out on the intertransverse fusion. So I kind of stopped all that after I had some complications, and then I went to open, and I didn't really see the same complications once that was the case. Now you can argue maybe I'm not a good MIS surgeon. Yeah, I'll accept that. That's fine. But I'm very comfortable with open TLIFs, and that's kind of my standard of care because I'm not seeing the same complications I was getting when I was doing MIS TLIFs. So endoscopic, I'm still a little wary about, but what I like about it is the concept of it. And what do I mean by this? It's the equipment and your technique is what makes this all possible. Maybe I just don't have the technique, and I'll accept that. That's fine. But the equipment's there. It's gotten much better, right? So really what it is, you're getting ultra MIS access to the disc through Camden's triangle, right? Once you get access to that disc, the case is over, right? That's it. It's done, right? Because I remember when I was in residency, I would work with one of my attendings who was an aneurysm surgeon, right? And it was like, and once he localized down to the optical carotid triangle, he saw the optic nerve and a carotid, right? For, let's say, PCOM aneurysm clipping. He's like, oh, okay, the case is done. That's it. I know the anatomy. I know all the anatomy, right? Same concept here. Once you're down to the disc space, the case is done, right? It's all about your instruments now and doing an adequate disc space prep. And that's the key here, okay? I guess I found it challenging in my practice, but here you have all the equipment. So there's innumerable instruments now, including, I can't remember the name of it, but I remember in a spinology lab that I did, it was like this, I'm blanking, maybe someone can put in a chat box. It looks almost like a roto-rooter. It's like a metallic silver, almost like a piece. They just kind of slide in and out of the disc space, and it literally roto-rooters disc space, takes tons of disc out. It's awesome. And you can attach it also to a drill and really get a lot of disc out, which is pretty awesome. So you have tons of instruments now, angle instruments, long instruments, whatever you need to get as much disc out and really decorticate the end plate. So once you ultimately get your, and this also makes it all possible too, are these expandable interbodies, right? So you can get a very tiny interbody into the disc space and expand this and get that foraminal distraction, get that height that you want. And once you get that in there, that's essentially your interbody fusion, right? So now the rest of the case is get your screws in, right? So you're basically done once that part is over. So theoretically, you're really doing something nice here. This is all possible with this endoscopic approach, which is nice. Now, whether fusions are happening versus instrumentation is a different story, right? Again, this is all has to do with technique. This all has to do with comfort. It has to do with some of the, what I call kind of the extra things you do, like if you're getting some iliac crest via MIS style, or you're using BMP. These are all kind of things that factor into this of how successful your fusion is going to be. This is easy to, wire brush. Thank you, Brian. It's easy to instrument, right? It's much harder to get a fusion, right? So, I mean, it's not that hard to, it's like, let's say like you're doing a cadaver lap. How hard is it to get your screws in, put your inner body in? What's the big deal, right? But come 1-2 months, so that patient subsides and pseudos and pops that cage back and its screws are in crazy places, right? What have you really done for this patient? And that's why I say, I can't tell you how, in my practice, how many, in many ways, I think Dr. Mike, are you here by any chance? Yeah, oh, great. You said this once to me, and I love it so much because it's so true. In many ways, the most dangerous surgery a patient can get is an MIS TLIF. How many times have I seen this spine journey occur because it all started with a poorly done MIS TLIF, right? Actually, Mike, if you're on, do you think you can maybe chime in a bit? Okay. All right, I won't wait. I'll keep moving. So, yeah, I mean, I can't tell you how many times I've seen it. And this is the same concept here, right? It's easy to get the instrumentation. Well, I wouldn't say easy, but you can get the instrumentation in. It's much harder to get a fusion here. Now, I will say what's nice also, and I should add this in. I forgot to add it in. I was going to put it in. They're now coming out with almost like fiber optic scopes where you can kind of drop it down and look inside of this space and see how much disc space prep you've actually accomplished. And you can really look around and see what's happening. And then based on that, you can go and do more. Okay. And that's nice. That's going to be kind of in many ways a significant game changer. During my fellowship, we did this, and we were doing open TLIFs, and we were just taking out tons of disc, right? They told us just take as much disc as possible. And when you're done, whenever you just, whatever your standard practice is, drop this scope down, take a look and see how much disc is left, right? And, we're aggressive and maybe even more aggressive because we knew we were being studied. You drop that scope in, you take a look around, you cannot believe how much disc is left. And this was a very aggressive, very methodical surgeon I was working with. It's shocking. There's so much disc left. Even if you think, oh, there's nothing left, right? There's a lot more than you expect, or a lot more than you think. So anyway, let me just move on here. So so it's nice. The endoscopic TLIF is a nice approach, and I think that as the technology is improving and our instruments are improving, we're really going to be able to do this and do it in a way that we're going to get fusions, right? Because we don't have the long-term data yet on endoscopic fusions, but as comparably to, let's say, open TLIF, right? We have tons of data on that, but we don't have as much data for the endoscopic stuff. So I'm still a little bit on the fence, we'll see, but just given my own personal experience with MS TLIFs, but I think that this is really the way to do it. And I think that once we get comfortable with this, we're not going to see these pedicle-based distraction systems anymore. The mini open TLIFs, it's just going to pretty much be endoscopic or open, and you just choose which one you want, because the endoscopic is really going to be superior to the tubular TLIF or the pedicle-based distraction systems. So again, what's nice about this as well is it opens up, if this is important to you and your practice, it opens up the possibility of doing these procedures awake, which is really nice. And I kind of, again, was very skeptical about this at first, and I don't know if I'm 100% a believer, but I've thought about it more, and I do not think it's possible other than the endoscopic approach. It's going to be very, very challenging, and I think that with the endoscopic approach, you can actually make this a reality, and very much so. And once you develop the workflow, and I think more importantly, once you have anesthesia that's comfortable with doing this, you're kind of home free. Like this is a very nice, I think it's a very nice procedure, and it can also help build your endoscopic spine practice, right? So indications, right? So doing a posterior foraminotomy cervical, this is beautiful. I think this is so beautiful. I haven't done one yet. I haven't seen one yet, but I love this so much. I think that this is truly the way to do it, is the endoscopic foraminotomy. in the cervical spine. This is, I do a lot of posterior foraminotomies. It's basically my go-to for unilateral with dick without significant neck pain or motor weakness, and with a, let's say a unilateral osteophyte. I mean, this is my go-to. I love posterior cervical foraminotomies. These patients do fantastic, and I think if anything, it's underutilized. But the problem is there are a lot of issues with the tube. It doesn't sit right. It's kind of a big incision. It's not that small. You do sometimes get this like hollow, this paraspinal muscle hollow there, and it's not without issues. But with endoscopy, you're talking about an incision like this big. I remember, I think Dr. Gardaki put a picture on Twitter illustrating this point. It was such a great picture, truly, like perfect. I think I don't remember when you posted Dr. Gardaki, but it was really great. I just remember that in my mind. I just remember how excellent that was. And this is really, I think, an excellent approach. I don't know about going anterior, doing a discectomy anteriorly. I've seen some papers about this. I just did a video about this, but I think this is a little bit pushing the indications. If you're really that comfortable doing it, I mean, kudos to you. I don't ever see myself doing it this way. Then there are also transpedicular approach in the cervical spine. I think this is way too risky. I've only seen this in some of the very few select papers. I think this is kind of like one of these chest thumping kind of, oh, look what I can do through a endoscope kind of thing. I don't really see the benefit in this. So, okay, circling back. What are my opinions? So when I first started, these were kind of my opinions about it. I was very skeptical about it. I'm an open deformity guy. Where is this really going to help my practice? I don't really see it, right? What's the benefit of the endoscope versus the tube? So I was kind of neutral negative, right? So there was a lot of hype, a lot of marketing, a lot of posts on LinkedIn and Twitter being like, oh, look what I can do through an endoscope. And it was the same people over and over again. I didn't really see two of my colleagues buying it. And that's where I feel is really where you know something is good, is when you see your partners, you see the people that you know and you respect, your mentors, people you train with. Hey, I tried this endoscopic, it's pretty good, right? And and you see them doing it, you see the people you interact with, that's when you kind of know it's good. It starts building a fire. But when it's so just like 50 people doing the procedure and talking about how great it is, it's hard to buy. But I'll have to say that my opinion about this has tremendously changed. And as I'm doing more of these, my partners are coming to ask me, hey, can I come and just see this? Because it's interesting. I like how you're doing it. Like they ask me questions about it, right? And I will say I'm a full believer now. I think it's fantastic. I think it's a great procedure. I think it really, really is superior in many ways to the traditional open and tubular approaches when it comes to discectomies, decompressions. I mean, you're really attacking the root cause of the problem, which is generally foraminal, right? It's generally foraminal is the problem, and the lateral recess. That's your problem, right? You're going from outside in. You're preserving all the ligamentous complex. You're preserving all the facet joints, the synovial capsules around these things. You're not disturbing them at all, which is great, right? And you're decompressing that nerve, and you're visualizing the nerve. You look and you see what you did. It's great. And again, another thing I didn't like about it was kind of my own experience, but really what it is, I think what took me the longest to kind of get my mind around was that it's not even, I wouldn't even compare endoscopic foraminotomy to open and tubular. It's totally different. It's not even the same procedure. It's a completely different thing. And in and of itself, it's an outstanding procedure. It really, for all the reasons I mentioned before, it's really really superior in many ways. So this is just some pictures I took of my my first endoscopic case. This is Brian. He's one of the reps, and honestly, he was like the guiding light, whispering in my ear, telling me to calm down during the case, during this procedure itself. What was nice was, and this is actually the first time I was doing it, so what was nice in particular is kind of just showing you the setup. So you have the C-arm in the field, everything's prepped and draped, you have your scrub tech here with all the instruments down here, and you're just staring at a screen, you're doing everything with the screen, which is nice. You're talking about an incision that's literally a stab with a 15 blade, maybe slightly larger with that. So it's really, really nice, and I'm hoping to do a lot more of these. Now, some of the things that people say about this that I want to touch quickly about before I finish is learning curve. They're saying, oh, it's a very significant learning curve. It's difficult to learn. I would say, honestly, it really wasn't too bad. I mean, if you're comfortable with like kyphos and you're comfortable with kind of getting access with a guide, the JMCD needle, or in this case, a spinal needle, it's really not that bad. It's really, I mean, when you're coming transforaminally, for example, which I would say, start transforaminal first. Do like 10 transforaminal cases, get super comfortable with that, right? And then start doing the translaminar approaches. With the transforaminal approach, you're so far away from anything bad, right? You're landing at just above the transverse process, just lateral to the supraarticulating process and way below the exuding nerve root. You're nowhere close to the descending nerve root thecal sac, right? You're like a mile away from all those things. So like you really, unless you kind of lose track and you don't get enough X-ray, kind of push things a little bit too far, you're not anywhere close to these things, which is nice. I will say though that one argument is that you do a lot more fluoro. Yeah, there is. And definitely when you first start, you're gonna get a lot of X-ray, and you should. So everyone's wearing lead. You have the C-arm in the field. That's something I think get ready for it. But I think you can also do this probably navigated. I wouldn't recommend it for your first case, but you can definitely do this navigated. Get one spin in the beginning and then just get your access with the nav, which should be just fine. You can probably do that with let's say we have the Zeem system at my hospital, so you can do that with the spine map, for example, and get access that way. And then really what it is, getting comfortable with the setup, because it's so different from what I was used to. I'm used to like using my loops, looking down, or using a microscope, right? Here you're looking at a screen that's at the foot of the bed or possibly across from you. And also what's nice about this as well, you don't really need an assistant. You're doing everything by yourself. It's a single surgeon approach. You don't need an assistant to retract, you need an assistant to suck or hold suction. You basically doing everything yourself. So in the event, so sometimes, so I work predominantly with physician assistants. Sometimes I don't, for whatever reasons, I don't get a PA to help me during a case. So in that instance, right, what do I care? You do everything yourself. It's so easy, and you're very fast out with this. Once you get comfortable with the instrumentation, you don't need an assistant, which is nice. So I would say that overall, it's been a very, very positive experience. I like it a lot. Now let's say, and Dr. Burchak said, hear from me in 6 months. I will have that. I'll give that talk. I've had any complications yet, but that doesn't mean anything. You just do it enough times and you do enough procedures, you will guarantee get a complication. So what's I think also nice about this is that what's the severity of the complication, right? You're talking about a very, very tiny incision. So if in the event you get a duotomy or it's very easy to, your theoretical risk of CSF leak in these cases is extremely low. If you have nerve root injury or reherniation, yeah, you get the same thing with open approaches. So it's not really any different, I'd say. Okay. What is your BMI cutoff for patient selection? It just depends on the procedure, but generally anything over 35, I'm getting a little bit on the fence. Now, if it's something from myelopathy, for example, I'll stretch those indications a little bit, but I do not like to operate on patients over BMI of 35. I'm very, very hesitant. Those patients are not going to, the best thing that patient can do is lose weight. They're not going to do better with any spinal surgery. Now, you bring up a good point. With endoscopic, right? You could theorize it's probably easier, I would argue, to operate on a high BMI patient versus open, right? And the reason I say that is that you have very long instruments that basically once you dock, what's the big deal? It's just a long instrument, right? Versus open, okay, or a tube. Sometimes don't have tubes that long, or you don't have with open approach, you're gonna have to make a huge incision in a very large patient. With endoscopic, you don't need it's the same small stab incision, which is nice. Yes, I was gonna say that Dr. Selby. I think another thing is that using a scope is taught earlier in orthopedic training, and I think my orthopedic colleagues are more comfortable using scopes than, as far as I've seen, the neurosurgeons I've worked with. We use scopes generally in the setting of skull-based surgery and transnasal approaches to the pituitary gland. So And in many instances, the resident doesn't do too much. The attending is doing, so we don't really get that much experience holding the scope and doing, things with the instruments. And if we do, it's not that common. So what's nice is I think with the orthopedic training, this is a very nice procedure. Probably definitely I would imagine much more comfortable doing endoscopic procedures than from anecdotally what I've seen my neurosurgery colleagues. Okay. I'm talking a lot. Okay, but I'm right on time, which is good. All right. So any questions, any comments, anyone want to chime in or say anything? It's okay if we are a little bit, we don't want to do anything. Okay. All right. So thank you very much. We'll end this a little early. I hope you all have a great night and enjoy the rest of your day. And hopefully we'll see you next week for the next session of Virtual Global Spine. Be well, have a great night, and I'll see you all later.